Hi, my name's Dylan Yogendra. I'm the managing editor at HIMSS EMEA. Today, I'm delighted to have with me Professor Claudia Pagliari, the Director of Global eHealth at the University of Edinburgh. Dr. Pagliari, can you give us a quick intro to yourself and your role, please?
Of course, thank you. Yes, I work at the University of Edinburgh Medical School, and my role is I'm involved in research as well as teaching on digital health and other areas of the digital society. So I lead a master's program in global eHealth, and I'm a theme leader of the NHS Digital Academy. And I also work with the World Health Organization as one of their members of their roster of experts in digital health, and have been doing some work with them on the misinformation pandemic recently. And alongside that, I work with Scottish Government, particularly on ethical aspects of digital technologies, and lead a national expert group. And I'm also involved in the Data Intelligence Network for Scotland, offering particularly ethical, but also other inputs to that initiative.
So a breadth of expertise, quite clearly. We look forward to tucking into some of the topics that you're going to be addressing ahead of the HET event. Can you tell us how the data ecosystem has evolved during COVID-19 from your point of view, please?
I would say that the main characteristic of this change has been the speed. We are seeing real acceleration of things that were happening anyway, particularly in terms of the aggregation and use of population-based health data, but also in terms of other forms of data we're beginning to capture from outside the health sector, also from medical devices, and so forth, that have really sped up as we have worked in this fast-moving crisis, but also as our needs for remote care have increased. So these are probably the main characteristics. I think on top of that, we've seen a lot more acceleration and interest in the use of new forms of analytics to make use of this data. So particularly in artificial intelligence, or things that are being labeled as artificial intelligence, even though many of them aren't really that sophisticated. And this has led to perhaps more innovation and research than it has in terms of actual outputs, but we're seeing certain types of outputs enhanced by machine learning coming forward, particularly around vaccine development, for example. So really all of these things that were happening in the pharmaceutical industry using data, with the research and innovation community using data, with public health using data, but also clinical services using data, all of this has really, I think it really advanced to quite some extent. And around that also we've seen some changes in perhaps the caution that was placed on the use of data and some of the governance around the data, with efforts to speed up these uses of information as a response to the emergency, perhaps taking precedent over some of that slower, more cautious approach that we're used to.
I wonder if you can actually expand on the contact tracing element. Are there any learnings that you can share with our audience on that side of things, please, Claudia?
Certainly. My particular interest in this has been mainly the apps that have been used and analysing the ways in which these have evolved, the challenges that they have encountered, the value they might bring of certain types, and some of the controversial issues that have arisen, as well as this outstanding questions of who's using these today. So I've been tracking that to a large extent, and this was, absolutely fascinating in the sense that we clearly, it's very helpful during any kind of public health emergency or pandemic to have mobile data, to have a good sense of where problems are arising, to be able to use these technologies to contact people, for example, and also just to understand the spread of disease. So contact tracing technologies or apps, we're trying to do many different things. Firstly, they're a real mixed bag, in fact. So I was looking at them across the world and also the different options that were being proposed in Europe and the USA and so forth. And some of them are simple proximity monitoring tools. That's what we ended up with mostly. Others were symptom reporting tools that would allow people to look at geographic changes, for example. Others are, more about coercion, as they are in some countries, which are perhaps monitoring your location to make sure you obey the rules or you stick with your quarantine. So they have different characteristics in them, and they vary quite a lot also. And this was the particular reason for their slow introduction in many countries. They varied in terms of the amount of privacy they offered the user and how much personal information and how much information about other people you know or your movements, which people might class as being private information, is shared with a central authority. So this has been obviously a source of debate even in the UK Parliament around how private those things were, and has led to all sorts of trade-offs and decisions and debates and anxieties. And then overlaying on top of this, the apps which have been developed in many places, including England, have hit on various technical obstacles. Some of those to do with the technologies themselves and perhaps not fully taking into account user input or stakeholder input to make sure that they were going to deliver, and partly to do with the things that they needed to connect with. So those challenges we've encountered have led to some quite expensive failures and problems. But finally, we ended up with something which is potentially usable, but it's questionable whether it's being used as much as it could be, and what the challenges are just now. So that's I'm currently looking at that. So the challenge with that data was, how do we use these technologies in an ideal world? If we're thinking in a very optimistic way, we might get our phones and we've all loaded up something and we've all agreed to share information and our location and our symptoms, and we might link it to our monitoring devices, or we might point out when someone we know is ill. So what one can talk about these digital disease surveillance methods as real mobile, digital, data-driven health intelligence. So we have seen some examples of these tools working quite well, these much more kind of informationally invasive tools like the Zoe symptom study app, for example, which requires people to consent to it. And it wasn't an official government app at all, but it was asking for much more information. And we've got quite a lot of useful, not we, but the people using it have got quite a lot of useful information out of it, which presents quite a stark contrast with all of our concerns about privacy and so forth, which we're applying to the national app, which we're looking at as being something that must be absolutely privacy respecting for good reason, because it just needs to be able to inform you if you need to take further steps. It doesn't need to be sending your personal life to someone in a faceless a person in a grey suit somewhere. So I think this has been beset with challenges, and we've seen some real differences internationally in the acceptability and use of these tools, and particularly in terms of the data that they generate.
Could you talk a little bit about how you think we can reduce health inequities or health inequalities to improve patient outcomes from a community's perspective, please?
One has to think about this. I think it's very important to think about the optimistic view and the benign usage view. And I think there are many things we can do with better access to information about community prevalence, for example. But also being aware, and this is how the vision for the intelligent data infrastructure is configured, is that we'll have all sorts of other social information, we'll have other kind of locality-based information, retail information, all sorts of information, information from the councils and other sorts of services that will be able to build a rich picture of not only demand, but also need. Demand in terms of the health, or infection levels, for example, but also what services are available. Now, this is quite optimistic because often that isn't being joined up at the moment. And for example, the data is not going to provide us with the resources that we need in order to, give everybody an iPad if they've been kept at home from school, or provide food to all those people that can't afford it, or pay their heating bills when they're stuck at home, which is a real problem for those in poverty at this time of the year. And so we can't do that, but what we can do is perhaps help to inform some of that strategic decision making with more information, perhaps from the power companies, for example. I'm just saying, I'm just putting this out there. I think our problem up to now is that we haven't really had very good data. And when we do have data, we perhaps don't use it the way we ought to use it. Or when we become very ambitious about getting data, we start snooping. And when we start snooping, it puts everybody's backs up. And also when we start labeling, it puts everybody's backs up. Take, for example, ethnic inequalities in COVID effects, for example. It's been a huge issue. We know there are these inequalities. Now, if you are approaching this from a very kind of optimistic perspective, you'd want to know absolutely everything about each group and subtype them, and then perhaps design some interventions that are tailored. And you're doing this in order to reduce inequalities. Quite an ethical aim, but what happens when you start labeling everybody, and pretty soon you've got sort of, you are creating a potential for future discrimination if you start to say that certain people have propensities to illness and maybe costly in certain ways more than other people. So it's, there might be a level of discomfort there. So, and it's the same with impoverished communities in socially excluded areas of any ethnicity. That is this sensitive balance between the necessity of perhaps understanding through data, but ensuring that you can do something with that information and turn it into some improvement, and ensure that you do that in collaboration with and consultation with those whose communities it refers to. So I think those are some key issues from my perspective. But I think certainly there are also these much more practical things to do with public health and the delivery. And we understand it was quite clear from the initial centralizing approach that the government had, paying private sector contractors to create centralized systems, that perhaps we're not speaking to local public health providers and not sharing data with those local public health providers. It was coming to them. And so, of course, you've cut off your means of utilizing your local expertise and your local knowledge and linking all of this together. Fortunately, there's been some learning about that. And I think that perhaps that's the future, is this kind of more local intelligence combined with more, obviously population-based approaches. But, I think these things are easier said than done. Joining looping the loop from insight to action is easier said than done. And when the good thing is that when you do have data to understand inequalities, it creates a pressure upon those in the authorities who now have this data to do something about it, because it becomes much more transparent and it's much more obvious that something needs to be done. And so, in a way, it may affect change subsequently.
Fantastic. I think you've touched on so many pertinent issues there, Claudia. I think having an open-minded and kind of iterative approach to things is always kind of a positive. Not being afraid to fail fast, I guess. And that collaboration piece is so significant. It's something that we really believe in at HIMSS, obviously, as well. I'm so sad that we've run out of time now, but we look forward to learning so much more from you during the HET event coming up, and would like to take this opportunity to thank you so much again for your time.
It's my pleasure. Thank you.